Hello, everyone. Welcome to another edition of Implants Made Simple. I'm Dr. Robert Stanley, aka Smile Engineer, and I'm here with Aaron.
Hey, I'm Aaron, and I'm here to ask Dr. Rob some very pointed questions about implants and see what he's got for us. So today, what I wanted to ask you is, what is the strangest implant case you've ever come across?
The strangest implant case. You know, it's interesting. The moment you said that, the first thing that popped into my mind was a patient who had presented for full mouth. So we're going to take out her remaining teeth and we're going to give her implant screw retain solution. And in the workup process, we acquired a cone beam CT scan, and in her maxillary right sinus was an implant that had been avulsed in there into her sinus. And so at that moment in time, I didn't have any history on the implant. The patient hadn't reported anything about the implant. And so I was very careful to approach the patient in a very politically correct way and say, you know, was there ever a time where you had an implant placed and what happened to it and questions like that. And it turned out that she relieved my tension very quickly. And she said, yes, I had one placed. And she said, and it got pushed into my sinus. And so then I followed up with a question or two, and I said, so when was that? And she goes, about 10 years ago. And I said, okay. And I said, and what was the plan? And she said, well, she said that the doctor said it would be fine and that we would not need to retrieve it. Now, as an experienced dentist, and those that are listening are experienced, you know that when a patient tells you something, you take it with a grain of salt because it doesn't sound exactly like what a doctor might say. They may say something like, if it's asymptomatic, we may be able to leave it behind. But if it causes problems, please return to the clinic so we can address it. More likely the case, that was it. But nevertheless, 10 years have passed, and it's in the sinus. Now, the sinus is completely opacified. It is full on the radiograph of something, okay? And the bottom is this glowing dental implant. And she agreed to sign up for full mouth treatment, and I told her I would retrieve that implant during the procedure. So we did a Caldwell-Luck procedure, which is basically making a small little window on the side of the sinus. We accessed the sinus. And then the moment that we perforated the Schneiderian membrane, we got this, well, if you're a surgeon, this amazing result of all of this pus and purulence that came pouring out of the side. We actually have it on film, and I was staring at it going, team, please tell me the camera's rolling right now, because it was just a really powerful moment where all of this pus was coming out. I was like, okay, good. So we got the pus out. And then to retrieve it, it was rather simple. I took my very, very small surgical suction tip, and I knew visually I could see where it was, and I have a good sense of where it was in space. And I just went into that lateral access, and I just grabbed it with the suction and then pulled it out very, very carefully, almost like you would do playing the game of Operation as a child. And so we pulled it out, and then here's where the story gets really interesting. The implant that was used would be an implant that I would tell people is contraindicated for subantral placement. So basically going under the sinus for a lateral window graft or a sinus bomb, I would not use this implant. And here's why. The number one thing that I noticed about the implant is it was a parallel walled implant. And so when you drill a hole, let's say you're going under the sinus and the sinus floor is only 5 millimeters tall from the top to the bottom, and you want to place an implant and do a graft at the same time. So you're going to place a 10 millimeter implant, you're going to place the implant in the 5 millimeter native bone, and in the apical portion, you're going to graft that. So that's what we do all the time. So the minimum is 5 millimeters. So you don't want to go less than 5 to do this. When you drill a hole for a parallel walled implant, the hole is parallel. And so when you place a parallel implant, there is no wedging effect. The opposite of a parallel wall implant would be a tapered implant. And so a tapered implant is like a wedge And you can think of like a wedge that you would use to split a log, or you can think of like a doorstop that's typically a wedge that goes under your door. So you put the wedge under the door and you give it a little tug to set it. And as you tug it, it creates a lot of compression around it, and then it holds that position really well. So if you have a tapered implant going into the sinus, as you engage the hole, which if you're using the drills that come with a kit, the hole is tapered. So as the tapered implant bottoms out in the prescribed depth, it creates a really good amount of radial forces out into the bone and holds it in place. And so this is less likely to be avulsed into the sinus than a parallel-walled one. A parallel-walled one, there is no extra compression. So you say, okay, so now I just have the threads that are on the side of my implant holding my implant in. Now, if you guys have been listening to the channel for a while, you know about the 5-thread rule. And the 5-thread rule says you want 5 threads to engage in native bone to determine primary stability. Well, you could change this and say, I want 5 threads to hold the subantral bone in order to gain primary stability. Now, here's where it gets really interesting. This particular parallel-walled implant also had micro threads on it. So the crestal 1/3 of this implant had microthreads. The apical 2/3 had their macro threads. But the apical 2/3 the apical 2/3 of the implant was in air. It was in the grafted area in the sinus. And so that left a parallel-walled implant with very, very small threads to hold it in the bone. So to reduce the risk, it appears that the surgeon placed a healing cap. So a healing cap is when it's on top of the implant. If you looked at the implant from the side, you can barely see it. It's level with the implant platform itself, and it's very, very small. And historically, people would place these to reduce risk of someone applying forces to your implant and knocking it loose. Well, that makes a lot of sense, except for the fact that in this case, with a parallel wall, it doesn't create any resistance. And so the doctor at the time of placement avulsed it into the sinus, placing the healing cap. Now, what they may have been able to do is if they had placed a wide body healing cap where the diameter of the healing cap is bigger than the diameter of the implant, that healing cap may have prevented it from being avulsed into the implant, might have created enough primary stability, and might have healed just fine. But through a combination of events, that didn't happen, and it avulsed right into the sinus. So this comes back full circle to something that I talk a lot about, which is implant design matters. And when people say all implants work, yes, it's true. All implant designs work, but they all work to a different level of success. And so when selecting implants, it's very important to look at not only what the implant's made of, but its microgeometry and its macrogeometry to ensure that you don't have a case like the one I'm describing here. So to answer your question, that was the first one that popped into my head. When you told me that was the first one that popped into my head, was this avulsed implant into the sinus, because it had so many unique facets to the story.
Absolutely. You know, everything from a pus geyser to a lesson on implant design.
Yeah.
Can't ask for much more than that.
Right? All rolled up in one poor patient's experience.
Well, hopefully she was able to get a better solution for the full mouth.
She did. She got 6 beautiful upper implants and a screw-retained final zirconia solution, and she's happier than she could, and healed fine from the retrieval, and the sinus all cleared up too once we retrieved that implant from the sinus.
I'm sure that had to be at least some of a relief, right? Like she had to feel that to some degree?
You know, I think in my practice, when we see completely pacified sinuses, it's very rare that the patient presents with discomfort.
Really?
Yeah. I mean, I'll ask them, do you have any? And they'll say, a lot of times they'll just say, well, yeah, sometimes, but it's been like that for so long, I just kind of write it off. It's not like an acute discomfort that you would get from like a toothache or from even a headache. They just don't report that kind of discomfort. And it must be like a dull kind of sub-therapy level where they just don't feel it. Wow. Because they just don't report it. And we don't see a whole lot of them, but maybe 3 or 4 a year that when you do the radiograph, you go, wow, the sinus is really in bad shape. and they just don't report it.
That's another layer of strangeness.
Which brings me to another interesting case, because I did have one where, and this changed the way I actually treat those patients, where we had a completely opacified unilateral sinus on a patient. It was a friend. And I told him, I said, you need to go get this checked out by ENT. Okay. And he said, okay. And so about 6 weeks later, he calls me up and he says, hey, I didn't go. And I said, okay. He goes, but about a week ago, I got up and I couldn't see out of my eye. And his eye had gone blind, and he went to the doc, and it turned out he had cancer in his sinus. And so it changed the way I treat these cases now. So now I am very, very adamant that when I see a fully opacified sinus, that's not where you're even close to being normal, and it needs to be checked out. I don't just say, you should get it checked out. I say, you have to get it checked out. And on people that can't afford it, I'll send it over to radiology to have it read on my dime, just to be on the safe side, because I'm just not wanting one of those cases to be on my watch.
Yeah.
So, yeah, that really changed the way I practiced reading my CBCTs.
I can imagine.
Yeah.
Because you hear all the time, they're like, oh, you go to the eye doctor, the dentist, that can be a very important health checkup for you, but you don't really think about the level to which something could be wrong.
Yeah.
That could help with.
Yeah.
Well, thanks for sharing those stories today.
Absolutely. Absolutely. This has been another episode of Implants Made Simple. I'm Dr. Robert Stanley, Smile Engineer, out.